Dr. Prasanna, for a wonderful introduction. And I think what you're trying to do here is something that should be emulated across the country, if not across the world, because interdisciplinary management doesn't start after you've become a specialist. It should probably start in training as well. So welcome, very warm welcome to all the surgeons on board. Any of you interested in oncosurgery would probably have to know a little bit about radiation oncology as well. Over the course of the next 4 lectures, as I've been told, we will be trying to cover everything that we have in radiation oncology, which has to do with multidisciplinary management. But like is true for anything in medical science, it makes sense to start with basics. And that was the instruction given to me. Start with the basics of a subject which I don't think anybody outside of radiation oncology ever even bothers to know about. So this might not really, be of much interest in the sense that this could be things that you might have learned in high school first and then maybe forgotten about it because you got into MBBS. But what's important to know is it forms the basis of radiotherapy, which is basically a treatment modality which uses high energy X-rays or radioactive substances to damage tumoral cells and halt their growth and division. Now the question is that also damages normal cells. So how does it then affect or benefit a patient? So there is a basic difference of a cancer cell versus a normal cell, which is the capacity to repair itself. And this capacity is traditionally much lower in a cancer cell as compared to a normal developed mature cell. So this is the difference that is exploited by treatments like chemotherapy and radiotherapy, wherein subclinical damage to the cell usually causes cell death in cancer cells and can actually be repaired in normal cells. So this is what causes the therapeutic ratio or the therapeutic efficacy that we need for treatments like radiotherapy. It has been used for more than 100 years now, and we have learned a lot, not just about how to give radiation and how to make it safer, but also the fact that biology responds very differently to radiation at different doses and at different dose rates. All these terminologies I shall be discussing as we go along today. What is lastly most important is radiation is a very, very commonly used treatment in cancer. More than 2/3 of patients who go into treatment of cancer or through their cancer journey would receive radiation at some point, which is individualized to the need of the patient at the point in time when they undergo the treatment. So with that small introduction, I'll go into certain terminologies which are important, and I think from the point of view of an examination, this would be interesting for most non-radiation oncology postgraduates. So if you want, you could take a screenshot or a picture of this. So radiation therapy may be categorized into external beam radiotherapy, which is also known as teletherapy. Now, tele basically comes from the term at a distance. So telephone, teletherapy. This means treating a patient from outside without touching or without going near them from a distance. The other term is brachytherapy, and brachytherapy is basically when you go into the tumor, go into the patient, or much like what a surgeon would do, go inside and rather than resect out a tumor, place radioactive sources within the cancer and try to treat it from inside. Now, what is interesting is brachytherapy was the first form of radiotherapy ever practiced. And you'd be very surprised to know that this was actually introduced by Emil Grubb, who himself was a very famous surgeon. So it's basically surgeons who sort of popularized radiotherapy as a treatment for cancer, and with time, walked away from it and we took over. The third form of radiotherapy is radioimmunotherapy, wherein antibodies are tagged with radioactive substances and radioactive isotopes, and they go and attach themselves to cancer cells and cause local cell kill. And this probably is the most precise form of radiotherapy. One term that I think you should probably write down is the difference between radiotherapy and radiation medicine. They are not synonymous with each other, and I often see this being used either or, when referrals are made. So the difference here is a radiation oncologist or a radiotherapist uses radiation from sealed radionuclides. So basically means you cannot touch the radionuclide or the radioactive substance even if you wanted to, because it is either a virtual source, which is where you're creating radiation from electricity, or it is a source which is sealed inside something which prevents it from being, spilled out or contaminating the patient being treated. On the other hand, radiation medicine uses unsealed radionuclides, wherein you can actually touch the radioactive substance, or usually that gets injected into the body. So radioimmunotherapy is primarily the domain of nuclear medicine or radiation medicine, wherein they do treatments with the help of radioimmunotherapy. Although the doses of radiation and the radiation safety issues are common between the two, they are usually a separate entity, and we shall not be discussing radioimmunotherapy or nuclear medicine over the course of today's lecture. Now, external beam radiotherapy is the most popular form of radiotherapy, and I dare say the reason why radiation has become so lucrative and popular in modern times. It is usually divided into very many types, and for the ease of remembering and understanding, I've divided them into four categories, depending on the sources from which and the ease from which, or the types of radiation that is being used. So, photon therapy. Now, if you remember what photons were, photons are packets of energy, and these are typically electromagnetic waves. We'll be talking a little bit more about that going forward. So photon therapy could be done from cobalt-60 machines and linear accelerators. Now, in modern times, cobalt-60 machines have been kind of relegated into the backseat because they are thought to be primitive machines and they're old machines, and LINACs are the modern machines. But again, you'll be surprised to know LINAC is a short form for the term linear accelerator, which is a source for radiation. We'll talk about that too going forward. But cobalt-60 uses radioactive sources like cobalt, which is isotope of cobalt, which is radioactive in nature, and it generates gamma rays, which are basically photons or electromagnetic radiation. Whereas linear accelerators use the property of release of X-rays or high energy photons by decelerating electrons once they strike something which can stop the flow of electrons. So that is the basic difference between a cobalt and a LINAC, but both essentially release photons. The interesting fact is both of them were developed around the same time in the 1950s, but cobalt fell out of favor because of very many issues, probably outside the scope of today's discussion, and LINACs have taken over from there. Electron therapy is a treatment with particles. Electrons are, as you know, part of the atom, and they have certain unique properties which make them invaluable in treatment of certain very specific types of cancers. And electrons are typically produced by linear accelerators. So as you can see here, LINACs have an edge over cobalt-60 because they produce both photons as well as electrons, and therefore have taken over the world as far as external beam radiotherapy is concerned. Moving forward, there are other forms of radiation which are non-photon and non-electron therapies, which is fast neutron therapy and charged particle therapy. Now, fast neutron therapy is more of historical interest. It has its own place, but the toxicities are difficult to manage. So they are mostly of historical interest, but for the sake of an examination, this is still something that you would probably have to know. And they're produced by cyclotrons. Whereas charged particle therapy with proton and ion therapy is now gaining a lot of popularity because of certain unique features when it comes to dose delivery with these machines. And you're probably aware that the first proton beam therapy center in India has been set up in Chennai by a private organization. And the second one is coming up in ACTREC, one of my training institutes, in the very near future. So the first section of today's presentation would be about the radiation basics. This might be slightly tedious for surgical residents, but I think it makes sense to know a little bit about how a radiation oncologist is introduced to radiotherapy when they first start studying the subject. So we are first told about the types of radiation. The types are natural and man-made. Natural radiation, you will be surprised to know, are more than actually what you actually think they are. So you have solar radiation, cosmic radiation, and also background radiation from certain parts where you have a very high concentration of radioactive materials. Like the sea beaches of Kerala are supposed to have a very high level of background radiation, as is also true for certain areas of Jharkhand where you have uranium mines and so on. The other source of radiation is man-made, which has potentially a lot of uses, but is also deadly, as in creation of the atom bombs and the hydrogen bombs and so on. So our focus will be the production of ionizing radiation for medical purposes. So that brings us to where this is actually done, and this is the atomic structure. All of you are aware of what this is. It's got a nucleus and electrons around it. The electrons are negatively charged, protons are positively charged, and the neutrons typically have no charge. So moving on from there, what is radioactivity and ionizing radiation? And the term which is highlighted in blue is what you need to probably understand and remember. So radioactivity and radioactive decay is basically emission of excess energy from the nucleus of an unstable atom, and the decay results in decrease in levels of radiation over time, what we call the half-lives. So typically 4 half-lives of a radioactive atom make it unusable, or in other words, safe. It makes it lose its radioactivity in some sense, and that makes it safe for it to be disposed, and so on and so forth. Also, from the other perspective, it makes it useless from the radiation oncology point of view, because you can no longer get usable doses of radiation from the radioactive source. What does this produce? So what is the radiation that we're actually looking at? So you are all aware that radiation has a huge spectrum. They have lower energy and high energy radiation. So what is the energy level that you're looking at, and how do you define it? So ionizing radiation is the radiation that is sufficiently energetic to remove electrons from atoms, creating ions. And this is the first step of producing damage in a biological system. So the energy levels required to produce ionization will be covered when we talk about interactions of radiation with matter. So going back to the various forms of electromagnetic radiation, this term electromagnetic radiation again becomes important. If somebody remembers this from their high school days, electromagnetic radiation is a form of energy transfer which has two waves traveling at right angles to each other. One is an electrical wave and the other is a magnetic wave. So there are two components to it. The other property of electromagnetic radiation, it travels at the speed of light, travels through vacuum, and most importantly, the energy of this radiation would be a function of the wavelength and frequency. So a very easy way to remember this is cosmic radiation, energy, radiation coming from stars and from supernovae are so energetic that they typically cannot even be measured at times. So we have a spectrum which is primarily determined by the measuring equipment that you have, and that goes from gamma rays to cosmic radiation right down to microwaves and radio waves. So this spectrum is probably something that you may remember if you want. Starts from gamma rays, X-rays, ultraviolet rays. Visible light is the range of wavelengths and energy that our optic apparatus can detect. Infrared is typically the heat that we feel from the sun. So infrared is of lower energy as compared to visible light, which is of low energy as compared to ultraviolet, which is of low energy compared to the X-rays and the gamma rays. So ultraviolet radiation is not something that a radiation oncologist would use for treatment, but definitely it has its uses in medicine. You would probably remember the PUVA system of treatment of psoriasis and other skin diseases, which is used by dermatologists, which basically means that this energy of the electromagnetic radiation in the ultraviolet spectrum is not enough on its own to cause cell damage, but you need to add something onto it to produce the damage, and thereby you're able to control the regions of damage very well. But if you're exposed to very long durations, you might get sunburns, and that is exactly what happens if you do not, you take care and probably expose yourself too much to sunlight. So that is typically the energy range at which you would definitely be affected, but not to the extent your system would be affected if you have even more energetic radiations like cosmic radiations, gamma rays and X-rays, which have the capacity to damage the DNA of the cell, primarily because these are ionizing radiation which can produce ions inside your body. Now, I spoke about linear accelerators taking over the world as far as external beam radiation is concerned, so it makes sense to understand a little bit about what this is. So there are two terms here, a linear and an accelerator, and you'll be happy to know that the world wars which have actually helped medical science in a very big way, specifically World War II was responsible for the development of a medical linear accelerator, and that basically comes from the magnetron or klystron. These are equipment which are capable of accelerating electrons in a very short space, and that short space is an accelerated tube. So you produce electrons from an electron gun, much like what you would do with an electrical bulb with the filament releasing electrons. Once the electrons are generated, you accelerate them with the help of magnetrons or klystrons through an accelerator tube. And as you can see from the image that is projected, this is a straight accelerator tube. And that's the way the word linear comes in. So linear accelerator tube causing acceleration of electrons. And once you've accelerated them enough, you basically stop them. So you stop them with something called a treatment head, which has a target which is capable of stopping electrons. And the moment the electron gets stopped, the entire energy of the electron gets converted to high energy photons or X-rays. So this is the process by which linear accelerators produce high energy X-rays, which can subsequently be controlled and shaped with the help of things called beam collimators, because this is where the beam comes out from. This is the gantry head, which basically houses this entire region. This is the straight region of the linear accelerator. This is the magnetron or klystron, which is actually accelerating the electrons across the linear tube. So in very, very short and probably very simplistic terms, this is how a linear accelerator would essentially work. But we haven't stopped there. We have made the linear accelerator even more sophisticated. And these machines probably are things that you would see in hospitals where you'll be working as if you ever choose oncosurgery. So this is what we call a true beam system. This is a cyberknife system. This is a halcyon. This is a helical tomotherapy system. And this is the latest kid on the block, not yet arrived in India. This is known as the Meridian, or the MRI guided, MRI guided radiotherapy systems, which has its pros and cons, but I don't think we will have time or the scope to discuss this today. So moving on, this is a term which is important: exposure versus dose, because if you're exposed to radiation, your body has to be able to absorb it in order for you to have a measurable dose of radiation. So just switching on the machine does not really make any sense unless you have a system which absorbs the energy which is being liberated or generated by the machine into the body. So basically, this absorbing material is the tissue of the body. And this tissue is what is responsible for creation of the absorbed dose. So these are two terms which are often used, unfortunately sometimes used interchangeably, which should probably not be the case. But if you are exposed to radiation, you need a body or you need material for it to be able to deposit a dose which will eventually cause the effects necessary. So how do you measure this dose? There are many ways of doing this. I won't go into too many details. So exposure is typically measured by Röntgen, absorbed dose by rad, dose equivalence by REM, and radioactivity by Curie. These are names and terminologies which would probably be sometimes brought up if you are looking at a gold medal or maybe an honors in your exam. But this makes sense for you then to know more about it. The SI units have actually changed from the traditional units. It's a coulomb per kilogram for exposure. Gray is the dose that we now use for dose. So you would come across older radiation oncologists and older surgeons. I know of a very senior surgeon who unfortunately is no more, and Dr. Sinha probably had the good fortune of working with him as well, who used to write the dose of radiation on his prescription and then refer the patient across to the radiation oncologist. And very famously, his doses used to be in rad because he was an older generation surgeon and oncosurgeon. At that point in time, rad was the dose terminology used for absorbed dose. And Sievert is what we use for dose equivalent. Radioactivity is used measured with the terminology Becquerel. So this again is Röntgen, which is used to express the amount of radiation exposure and is abbreviated with a capital R. It is independent of the time of exposure. It doesn't matter how long you're exposed to it, the Röntgen value will remain the same. On the other hand, the rad or the gray, it relates to different types of radiations and the energy that they impart. It is the basic unit of absorbed dose, and 1 Röntgen of gamma radiation exposure results in about 1 rad of absorbed dose, but that is now different when you come to gray. REM is the biological effect of the dose, and 1 rad of exposure results in 1 REM of dose for gamma radiations and beta particles, but for alpha particles, 1 rad exposure results in 20 REM of dose. Now, why did I bring this up? This is primarily because the biological effect of radiation, which you are measuring with the help of REM, is also dependent on the kind of radiation that is being used. So, if you're being treated with beta rays, electron beam, gamma rays, your radiation efficacy or radiation effect would actually be much lesser as compared to if you are being treated with alpha particles, where the dose of radiation would be much lesser, because for an equivalent dose of radiation, the REM value or the Sievert value is much higher. So that basically translates to alpha particles being much, much more biologically active as compared to the other forms of radiation. The downside to this is alpha particles are extremely difficult to produce and use, and therefore we have no usable alpha radiation centers, at least in this part of the world. Exposure rate is something again which is important, which basically can be sort of explained by the fact that if you're sitting right next to a fireplace, you feel much warmer in a very short duration of time as compared to if you're sitting much further away. So the same thing holds true, and that is true for the infrared radiation which is coming from the fireplace, the energy which is being sort of deposited into your body, and the convection of the air in the room. Not only that, the same thing can also be sort of extrapolated to external beam radiation, where the rate of exposure is also an important determinant of the biological efficacy of the radiation. So if you're exposed to, say, for example, 2 gray of radiation over 1 day, the efficacy might be absolutely zero. On the other hand, if the 2 gray is delivered inside the body within, say, about 5 to 6 minutes, then the efficacy is much higher. So it is expressed in the term of Röntgen or milliröntgen per hour. This is a terminology which we usually use when we are talking about brachytherapy rather than external beam radiotherapy. But it's important from the point of view of an examination to know what exposure rate is and how it might affect the biological system. So these are the SI units, and you can take a screenshot of this if you want. This is just for the point of view of examinations, and if you ever feel you need to know more, you can always get in touch with me through CCC. Now, coming to interaction of radiation with matter, which probably is the crux of today's presentation. So when radiation is exposed, as I said, absorbed into the body, how does it act? So 3 possible occurrences when photon and energy radiation, which is X-ray or gamma photons, in the primary beam pass through matter. So no interaction at all. Nothing happens to the beam. The way it goes in, it comes out the very same way. This is known as transmission. The second is absorption, and the third is scatter. Scatter is basically the beam coming in one direction and going out in a completely different direction. So the second and third factors are responsible for what is known as attenuation of the beam after it has passed through the body. So this is a diagrammatic representation of the same thing. So you have monoenergetic photons, single energy photons going into the body, getting attenuated, getting scattered, and getting absorbed. And what comes out is multiple energies of photons, because the attenuations have been heterogeneous across the material that is being radiated. So this is basically attenuation, and we'll see how this can have medical uses going forward. And that brings us to the 3 main interactions of radiation with matter. This is basically photon energy or photons interaction with matter. So you have what is known as photoelectric effect. As I said, this effect is extremely important in diagnostic radiology. So the X-ray images, the CT scan images that you see, the differences between bones and air and soft tissue and fat and so on, is basically because the X-ray beams of a lower energy which interact with matter through photoelectric effect can be affected by the density, and we'll know a little bit more about that going forward. And therefore you can have different levels of blackening of the X-ray film, which can help you understand the pathology inside or the physiological structures inside, at least structurally. The second is Compton stator, which is also important in diagnostic radiology, and pair production, which is both useful in therapeutic and diagnostic radiology. So we'll come to photoelectric effect first. All of the energy of the incoming photon is totally transferred to the atom, and following the interaction, the photon ceases to exist. So it's basically like being shot by a bullet and getting scattered through that. The incoming photon usually interacts with an orbital electron of an inner shell. So you remember the KLMN shells, which we used to learn in the Bose model of the atom in high school days. Well, that still exists, and this is the K shell, which is usually affected by the photon, and the orbital electron is dislodged, and the dislodged the electron gets replaced by an external electron, which is subsequently, so I'll show you a diagram which might be able to sort of explain this better. I won't go into too many details. So let's see. Yeah, so this would be an easier way of understanding. So you have an incident photon knocking out an orbital electron, which is getting replaced by an electron from an outer shell. So you have what is known as characteristic X-ray. So you have electron energy levels for each individual orbital level of the atom, and these electron energies, when these electron energies are liberated, they are of a predictable value, and this comes out as characteristic X-rays. So this part is extremely important when you talk about diagnostic radiology. So you have byproducts of photoelectric effects, which are photoelectrons, characteristic photons, which are basically photons bearing an energy which is equivalent to the difference of the energy levels between the 2 orbital electrons. And this probably is the most important slide when you talk about photoelectric effect. Take a snapshot if you want to. It depends on the energy of the incident photon. It depends on the atomic number of the irradiated objects. It increases as the photon energy decreases and the atomic number of the irradiated object increases. So if you ever go to a diagnostic X-ray machine, you will see that you can actually increase and decrease the energy of the photons being liberated, or the X-ray being liberated from there. And this is basically going to affect the quality of the image that comes out. So this is the reason why the probability of photoelectric absorption is roughly proportional to Z by E cube, where Z is the atomic number, E is the energy, and the cube is the value telling you how much change it might, predict for when you're looking at photoelectric effect. And it is prevalent in the diagnostic kilo-electron volt range of 30 to 150 keV. So this is the range for photoelectrons or photoelectric effect, and this is typically a very useful effect for diagnostic radiology. And this is the energy levels that you usually see being used in diagnostic radiology. So what does this all mean? It basically means bones are most likely to absorb radiation as they have a higher Z. This is why they are white on the film. Soft tissue allows more radiation to pass through than bone because they have a lower atomic number or a lower density. These structures will appear gray on the film, and air containing structures allow more radiation to pass through than soft tissue, and they appear black on the film. So these would be the three levels of attenuation that are achievable because of the difference in the density and the atomic number of the material that you're radiating. So typically what you get on an X-ray on a CT scan. Next is Compton scattering. This is important from the radiotherapy point of view, where an incoming photon is partially absorbed in an outer shell electron and absorbs enough energy to break the binding energy and is ejected out. What happens now is that this ejected electron is now called a Compton electron, and not much energy is needed to eject an electron from an outer shell. The incoming photon continues on a different path with less energy as than the scattered radiation. So this is what Compton scattering would look like diagrammatically. You have an incident photon knocking out a Compton electron and a scattered photon coming out from there. What you will appreciate here is, since this is from a distance from the nucleus, the dependence on the Z or the atomic number actually decreases. And this is something that we are very interested in when it comes to radiotherapy. So what are the byproducts of Compton scatter? You have a Compton scattered electron, has enough kinetic energy and capable of ionizing atoms. And this is the property that we're looking for when you're talking about radiotherapy. You want to ionize the atoms so that they can, intercalate with DNA and cause DNA damage. It finally recombines with an atom that has an electron deficiency and becomes neutral again. The scattered X-ray photon with lower energy will continue in its way, but in a different direction. It can interact with other atoms by causing more photoelectric effect or Compton scattering, or it may just come out without causing any further problems or any further interactions within the patient. Now, so the probability of Compton scatter occurring will increase as the incoming photon energy increases up to a certain limit, and then decreases as the photon energy decreases, because you're now giving more energy than is actually required to knock out electrons from the outer orbit. So what happens then is what we'll discuss in the next section. But here it is independent of the Z of the absorber. So what that means is the effect would be the same on bone, would be same on soft tissue, and it would be same on air containing structures, something that you're actually wanting when you want homogeneity of efficacy as is required in radiotherapy. So the Compton scattering is extremely important when you come to radiation oncology or treatment of cancers or malignancies with therapeutic doses of ionizing radiation. And the energy range at which it is most important is from 100 keV to 2 MeV, so which basically tells you that you need more energetic photons than photoelectric effect for Compton scatter to occur, and that is independent of the Z of the absorber. Now coming to the third and the final way of interaction of photons with matter, this is pair production. Now the first statement, and this is extremely important, the incoming photon must have an energy of at least 1.02 MeV. This is primarily because this is a process of conversion of energy into matter and then matter back into energy. So 1.02 is basically something that you would need to create and destroy an electron. There are 2 electrons produced in this interaction, and pair production interacts with the nucleus of an atom, after which the photon disappears, and the transformation of energy results in the formation of 2 particles, one of which is a negatron, the other is a positron. Now this is important from the radiation oncology perspective, definitely, but this is something which is now being used in research, because with very high energy radiation that is used for treatment, most of this energy would then be transformed into positrons, which can actually be detected. So now you have radiation systems being developed where while you are doing radiation, you can actually do PET scans to understand what exactly is happening inside because of the positrons being generated in this process. This is a diagrammatic representation of pair production, and the 1.02 is because these two negatron and positrons would require at least that much energy to be produced, because each of them would carry a 0.51 MeV photon or 0.51 MeV energy with them while they're being produced. So what are positrons? Positrons are essentially considered to be antimatter, and please do not say this while you're in your exam, because that will take you to a very dark area which we know very little about. But they do not exist freely in nature and cannot exist near matter, and that's the reason why they get annihilated the moment they are created with the first electron that they encounter, and this is known as an annihilation reaction. This converts matter back into energy, and both the positron and electron disappear. Two gamma photons are released with the energy of 0.51 MeV, and this has to be in opposite directions to each other because they are being liberated at the very same time with the same levels of energy. This can actually be detected. This is what I was talking about when you talk about radiation producing images while treatment is happening. So pair production, the gamma photons may interact with matter through pair production or Compton scatter. And it is used for PET tomography, which is a nuclear medicine imaging procedure. It is also used in radiation therapy, as I just mentioned to you. The probability of pair production increases by increasing photon energy, as you can already guess. And since this is an interaction with directly the nucleus, it increases with the atomic number approximately as Z square. So it does have a propensity to be heterogeneous, but the level of heterogeneity is definitely lesser as compared to photoelectric effect. An interaction which you're mainly using for diagnostic radiology. So this is just a very brief summary and trying to kind of recollect what we just spoke about. So with the Z, or the atomic number of the absorber, you will have an increasing Compton effect, you have an increasing photoelectric and pair production. Across an energy level between 0.1 to 10, you will have Compton dominant effects, and then below that you'll have photoelectric domination, and above that you will have pair production domination. So this is just a diagram which you might remember to be able to sort of recollect what I just spoke to you about. You may not need as many details, but it definitely makes sense to know a little bit about the ways in which these interactions happen and the energy levels and the dependence of the Z, or the atomic number of the absorber that is being radiated. Now, a very brief overview of interaction of particulate radiation. This is very different to what happens in photon radiation. So alpha particle ionize by attracting an electron from the atom. Beta particles ionize by repelling an electron from the atom. The basic principle remaining the same. You have to create an ion in order for you to be able to create a biological effect. And energetic charged particles interact by matter by electrical forces and lose their kinetic energy by excitation, ionization, and radiative losses. And there are charged particle tracks. Now, the particle tracks would be dependent on the mass of the particles. So that's very, common sense to understand. You don't need to really know too much of physics for that. So if you have a larger, heavier mass, they have a dense and linear ionization track. You have a lighter and a smaller mass, like an electron, you will have path lengths which are very variable. So this is what it exactly is. A is what an electron particle would produce, a very variable path length, and alpha particles would produce a very linear and predictable path length. So it therefore is kind of understandable that an alpha is more dependable when you are talking about radiation dose delivery in a system as compared to an electron beam, because of the variable path length and the the haphazard way in which electrons might tend to get deposited across the system. So that brings you to linear energy transfer, which is basically the energy transferred from the particle per unit length of the path, and it is expressed in the terms of electron volts per centimeter. In a charged particle, it is proportional to the square of the charge and inversely proportional to its kinetic energy. And high linear energy transfer radiations are more damaging than low linear energy transfer. So basically what we initially saw, alpha particles and protons being charged heavy particles have more damage and have a higher sievert level or a higher biological activity as compared to photon particles. This also brings us to a very interesting thing. So if you look at point number 3 here, the energy transfer of a charged particle is proportional to the square of the charge, which is constant. You can't change it. What can you change? You can actually change the kinetic energy of the particle. So a faster particle versus a slower particle. So when this particle enters into matter or enters into tissue, it would start getting attenuated, it would start interacting, and at some point it would lose all its velocity. And this is the point at which all its energy tends to get deposited. This is the concept of what we now call the Bragg peak. A Bragg peak is essentially a point within the tissue where the entire radiation of a charged particle gets deposited and no energy gets deposited beyond it, which is beautiful when it comes to radiation, because one of the problems that we face with non-particulate, non-charged particle radiation is tends to have a component of transmissibility. So you have energy deposition beyond the region that you're actually wanting to target, as opposed to charged particle radiation. So please remember this, the concept of linear energy transfer and the concept of Bragg peak. What is specific ionization? It's the number of primary and secondary ion pairs produced per unit length of a charged particle's path. Expressed in ion pairs per millimeter, it increases with electrical charge and decreases with the increased incident particle velocity. And Bremsstrahlung is radiation loss. Bremsstrahlung is basically a German term which essentially translates to deceleration or breaking radiation. So when you break something, radiation gets produced. So it's basically the concept of conversion of electrical energy to electromagnetic energy. So you basically decelerate electrons and produce X-rays. So energy emission by Bremsstrahlung varies inversely with the square of the mass of the incident particle, and therefore you have protons and alpha particles producing less than 1/1,000,000th the amount of Bremsstrahlung as compared to electrons. So which therefore means that electrons are the most efficient way of production of X-rays in the charged particle subgroup. This is what Bremsstrahlung looks like. I won't go into too many details of that, but please remember this is the basis of an X-ray tube, which is what we still have inside a CT scanner and an X-ray machine, and also the basis of the linear accelerator. But Bremsstrahlung can be taken to the next level when you have electrical accelerators like a linear accelerator. Now, interaction of neutrons with matter, historical interest only, but please remember the basic reason why we are talking about this is the interaction of neutrons with matter is still used, although not for therapeutic treatment of cancers. It is used for production of artificial radioactivity. So when you have a cobalt machine in your hospital or a brachytherapy machine with a radioactive source like an iridium or a cesium or a cobalt, you need to get it replaced from time to time because the radioactivity decreases with time. Now, how do you get a new source? You basically send it back to BARC, to one of the the places in the country that you live in where radioactivity, artificial radioactivity can be sort of done, because this is a very carefully regulated system. And there, these are radiated with fast neutrons, which essentially make them radioactive all over again. So fast neutron therapy is not so much used for clinical radiotherapy anymore, but it is more used for the creation of radioisotopes for treatment of cancer. So we won't go into details of that. This is probably too much for a surgical oncology resident. But if anybody is interested in knowing more about this, please get in touch. I'll be happy to send you screenshots of the slides that I just skipped. So section 2 is biological effects of radiation, which again would be too much for us to digest if I went into details of it. But just to tell you, it is dependent upon exposure, that is duration of exposure, like we talked about a little while back. So it could be acute, which is limited time of exposure, and chronic, which is extended or repetitive exposure. It is also depend on the level of exposure or the intensity, and it also depends on certain biological factors. So ionizing radiation, as we mentioned, is when you have the capacity to strip away electrons from atoms, and this ionization would eventually damage DNA and other structures inside cell and could result in incorrect repair and cell death, which would cause mutations which might further lead to cancer. So with that very, very short, probably a little bit of a physics-based introduction to radiotherapy, I'd like to end with this, that it has been a subject which actually has seen probably the biggest change in our lifetimes, because we have come from cesium machines which were sort of relegated to the basement of most hospitals, with very little medical staff interested in finding out more about it, two departments which have now become the showpiece of corporate hospitals, where people are taken to show them how good their hospital is. So there has been a lot of development, and literally, there has been a sea change in the approach of both medical professionals and patients towards radiotherapy. The reasons for that is we have new delivery technologies. The ways in which we can deliver radiation has actually changed. We can now do what is known as volumetric modulated arc therapy. These terms I will be probably taking up in our subsequent lectures, but just to sort of whet your interest and the menu card for the next lecture, if you will. So this will be volumetric modulation of the radiation that is delivered. So within your body, volumes of tissues would be receiving different doses of radiation. Its derivation typically is a circular arc based delivery. So the machine is moving while radiation is delivering. It's very quick, safe and easy way of delivering treatment. You have the CyberKnife system, which most of my colleagues seem to know about, at least the terminology, but very little about what it implies. The CyberKnife is actually a mini linear accelerator which is mounted on a robotic arm. This arm can move around the patient and deliver radiation, fire the beam in from various directions. And it uses very, very small beamlets to create very, very precise areas of radiation delivery. So what is probably, kind of understandable from this description is that CyberKnife is not for very large tumors. CyberKnife is therefore not for all cancers and all cancerous situations. It has its own role and it has very important place. And that has to be understood before we start talking about CyberKnife as panacea for radiotherapy patients. Next is IMRT, and IMRT has been around since 1997. It basically is the modulation of the fluence of radiation beam by creation of what we call beamlets, and thereby modulating the dose that is delivered inside the body according to the anatomical shape of the individual patient. So probably radiotherapy is the first, IMRT is the first form of personalization of cancer treatment that we ever had. And we've had this since 1997. So it's no longer the one size fits all in radiation. It is what this particular patient's anatomy and disease process requires, which is designated by a planning system, which is essentially a very powerful computer, which helps us modulate the beam to the requirement of the patient. Proton beam, as I just mentioned, is a form of charged particle radiotherapy. And remember the linear energy transfer and the subsequent Bragg peak making radiation delivered at a point and no radiation beyond it. This is the beauty of proton beam, and proton beams have again a very big role to play, especially in children, where you would not want areas beyond the cancer, beyond the target that you want to treat, to receive any dose of radiation, primarily because there are long-term effects of radiation which could be harmful for growing bodies. And finally, image-guided brachytherapy. So we spoke about brachytherapy and Emil Grubb using brachytherapy way back in early 1900s. We now have a situation where we use artificial intelligence-based technology to deliver doses of radiation from within the body with image guidance. And this is primarily done with planning systems which are unlike anything else that you might have seen in medical science. They would probably be more powerful than computers that are being used by researchers in physics labs, but they are commercially available now, and they are using basically modeling to sort of track individual photons as they are being created within the radiation field, and to try and sort of map the areas through which they would pass and the kind of interactions that they would do within the body, and thereby give you a dose cloud which you could use around your cancer and thereby be accurate in treatment of a particular target. So we have improved imaging technology, and this is because of advances in the diagnostic radiology group and our colleagues across the board, from nuclear medicine to radiology to other areas, where better quality positron emission tomography scans with multiple isotopes, not just 18-fluorodeoxyglucose, you have
For prostate, you have now PSMA based scans, which is prostate specific membrane antigen based scans. You have CMET scans for brain tumors. You have meso scans for hypoxic regions. You have FLT scans for understanding the proliferative capacity within the cancer. So not being a homogeneous target, you have areas of the cancer which are growing, areas which are necrotic, areas which are hypoxic. You can actually image those areas out even before you treat a cancer, and use technology like IMRT and VMAT to precisely deliver heterogeneous doses of radiation even within what looks like a single tumorous region inside the body. So this is very, very exciting as far as radiotherapy delivery is concerned, primarily because of improved imaging technology that we have. Third, we spoke about exposure rate. We spoke about how long you get exposed to a particular radiation dose, and how much radiation is being used for a particular period of time. So if you were to increase the doses of radiation which is delivered over a period of time, say instead of taking 2 gray a day, you suddenly are exposed to 20 gray a day. Would the biological effects of this radiation remain the same? Would it be different? If different, how different, and so on? So what we essentially see is increasing the dose of radiation per day, which is termed as hypofractionation, has more biological effect as compared to standard radiation fractionation, which is about 2 grays a day. In the next lecture, we'll be talking about practicalities of radiation and how we prescribe radiation across cancers, in the body. There you'll be understanding more. Just to whet your appetite again, by hypofractionation, you're increasing the biological efficacy, but also increasing the side effects of the same, that is when it is being used. So what you need there is improved imaging, improved delivery, and improved ways of trying to modulate the doses at the edges of your target, whereby you have very little dose outside the high dose region that you're using, and all the dose that you need within the target. So this is the concept of SBRT, or stereotactic body radiotherapy. The more fancy term for which is stereotactic ablative radiotherapy. And the final term here, SRS, is stereotactic radiosurgery. And I'm sure when you hear the word surgery being used by radiation oncologists, it immediately sort of irks you a little bit. But let me assure you that Lars Leskill was a very famous neurosurgeon, and he's the one who came up with SRS. Again, surgeons did not want to run with it, so we took it and started using it on our own. So this is again something that a surgical oncologist or neurosurgeon gave us, and we developed on it. So making radiation more effective or more safe is what is again the aim of using other therapies with radiation. So combination therapies where you use lower doses of chemotherapy along with radiation is known as chemoradiation. Across the board, there is a 6 to 15% improvement in outcomes, of course at the cost of more toxicities, and you have to be more careful, and the patient selection has to be proper. You have more molecularly targeted therapies which seem to be as effective as chemotherapy, at least in some patients, and can be replaced if used judiciously with same efficacy and definitely at lesser toxicity. So we talked about ions and how important ions could be going forward, and this is an area that we are looking at with things like boron neutron capture therapy and alpha particle therapy. And let me tell you about this. If anybody is interested in gastric cancer and you wish to travel to Japan to learn more about it, do take time out to visit their ion therapy centers and their boron neutron capture therapy. They're doing a fantastic job with that, and they're world leaders. And finally, theranostics. Nuclear medicine is not my department or my specialty, but this probably for me is the most exciting part of oncology at this point in time, wherein it is not just imaging with radionuclides. They are now treating with radionuclides, and this is not just for thyroid cancers, which used to be their bread and butter. You know about radioiodine therapy. This is one form of theranostics where radioiodine isotopes are not just used to image the residual thyroid, they are also used in a higher dose to treat and ablate the residual thyroid. The same thing is now being used for multiple other cancer indications like neuroendocrine tumors, prostate cancers, and pancreatic cancers, and so on and so forth. So in the future, in at least oncology, radiation oncology is extremely exciting. And I'm sure there are many, many babies amongst us, at least in medical science, who just can't wait to, dive into radiation oncology for their future. like to thank everybody for patient hearing, and special thanks to CCC and Dr. Udajit Sinha for asking me to be a part of this training program. Thank you.